So our first speaker today is my boss, Dr. G Boran. Professor G Boran, I beg your pardon. G Boran is head of clinical chemistry and consultant chemical pathologist at Tala University Hospital. He's clinical professor in the TCD Department of Clinical Medicine at TUH. Current research include the Celtic Ranges project supported by the National Children's Hospital Foundation and FAIR Test supported by Enterprise Ireland and Disruptive Technologies Innovation Fund. He's also held research grants for the HRB and the European Commission. Professor Boran is also course director for the internationally accredited TCD MSc in Clinical Chemistry and is associate editor of the Irish Journal of Medicine Science and has over 100 publications in laboratory medicine. Professor Boran.
Thanks very much. My gosh, I don't know what to do after that video. That's quite extraordinary. This is going to be deflationary, folks. I'm G Boran. Anne has asked me to talk about data everywhere, and I'll probably get to that. Now, I'm not going to be saying so much about this coronavirus here, but rather a bit more about the hyperinflammatory markers, like this ferritin molecule here. Now, Tony is adjusting something for me here. Very good. Oh, I beg your pardon, we're sharing the screen. I should have done that. I should know Zoom by now, but I'm a bit of an amateur on some of these technology things. Here we are. So I'm going to say a bit more about ferritin rather than the coronavirus, which you will have heard a lot about the laboratory diagnostics around that particular organism. Now, I'd first of all like to just give you a bit of a guided tour of the various ships in the sea, the various markers. And I'd like to tell you about setting up the storm diagnostics in our lab. And I'll tell you a bit about the levels of biomarkers that we saw. And also we did these dashboards that I want to show you, tell you a bit about. And also we developed a database and a biobank. And if there's time at the end, then I have a few little cases that I hope you might find interesting at the end. Now, the Wuhan clinicians, way back at the beginning of the year, noticed that a cytokine storm was occurring. There was lymphopenia, of course, with the virus, as you would expect, but there were major changes in markers that correlated with survivors, with survival. And there were positive responders and there were negative responders, as you would expect. And things like ferritin, CRP, D-dimer, IL-6, etc., were elevated, often markedly elevated. And there were other things, apart from the lymphocytes, that went down, like lipids and vitamin D, for example. So sometimes it's helpful to think of three different categories of these biomarkers. They all go up or down, whatever that thing is, in the cytokine storm. But you could think of them in three groups: infection and inflammation being the first group, and things like CRP and IL-6 ferritin would fit into that bracket. There's a second group of coagulation markers, D-dimer and fibrinogen. Now, I'm going to say any more about those because there is a talk this afternoon on that subject. Except to mention that with our blood gas analyzers, at least here in Tala, we noted that samples were very viscous actually, and it caused a lot of consternation, clotting regularly back in those difficult months of April, May and June this year. The third group then are markers, I call them comorbidity markers, in that they have responded in the storm, but they're also a bit doing what they say on the tin. So we'd use BNP to look for heart failure, for example, and there will be other markers like troponin, EGFR and glucose A1C, etc. Now, we eventually, towards the end of late March, early April, we implemented these markers here. Ferritin, CRP, D-dimer and fibrinogen were available between chemistry and hematology. And we de novo set up IL-6 and PCT. And in fact, there is a poster, I believe, in the electronic space somewhere, which will describe that process for you. And we also set up what we call COVID-19 test panels, which were basically modified ICU panels. And we used them a bit around the hospital, some little modifications to make it easier to think of ordering these tests. And we also did a bit of demand management initially because we weren't really sure where the numbers were going to go. And for IL-6, for example, we decided to do those only if the ferritin and D-dimer were significantly elevated. So a little guided tour. IL-6 is a cytokine secreted during the acute phase, and very high levels are seen in severe inflammation, and they correlate with poor outcomes. And along with IL-1, it produces fever, and along with IL-1, it's probably responsible for the COVID fever, for example. Its pathways are targets for novel antivirals, like there was a lot of talk about tocilizumab earlier on. In terms of its time course, it goes up around 6 hours, about a day it peaks, and by the second day, it's usually fairly well down again. So what I have here is a frequency distribution of the IL-6 values that we obtained in our laboratory in the months of April, May, and June during the first wave. And you can see that there's a sort of normal and not detected value there. But you can see that we obtained a very significant number of very elevated IL-6 values indeed. And to move on to CRP, now CRP wasn't really repurposed because we know that it's elevated in inflammation and it's an acute phase responder. But we have noticed that many COVID-19 patients had very markedly elevated CRP levels. It's driven by IL-6, of course. And here is, again, a nice frequency distribution. I was going to say I plotted it, actually, but I'd be lying, actually. Our very helpful team of scientists plotted these wonderful graphs, and they put in these helpful little axes for CRP that's not detected or low, mild, and then there's a sort of moderate marked category. And again, you can see that we obtained a very significantly large number of very high values indeed for CRP. Ferritin, you'd be familiar, of course, in terms of being a marker of total iron stores and its use as a diagnostic test for iron deficiency anemia. We also knew, of course, that it tends to go up in inflammation. But heretofore, that's been regarded as a bit of a nuisance effect, really, because it's sort of masking what you want to use the test for is to pick up iron deficiency anemia. Now, the Wuhan clinicians spotted this as well and basically repurposed this marker as a hyperinflammatory marker. And again, in Tala, in cooperation with our hematology colleagues, and again, this lovely graph was produced by one of the scientists in the lab. We've got the deficient range is marked there, which is the sort of range you'd be looking for iron deficiency anemia in. There's a reference range, and then there's what we call an inflammatory range. And again, you can see that there are lots and lots of very high ferritin levels coming through. Now, these frequency distributions, by the way, were all of the samples that we analyzed April, May, and June during the first wave, when basically every patient in the hospital was COVID-19. So there was very little non-COVID tests at all going through. Procalcitonin is a very interesting one. It's secreted from macrophages during bacterial infection and their elevated levels. And it's known that most patients with mild COVID disease, say WHO, on their outcome scale, 1 or 2, something around that order, have PCT values that are really undetected or normal. And there are also figures that are used, say around or above about 0.5 when bacterial infection or superinfection on top of, for example, a virus, would be becoming far more possible. And again, here is a frequency distribution of our PCT values during that first wave, April, May, June, all the patients basically, that all the samples that we received. And you can see that there are at least 100 plus with levels more than 2, which is very high. 50 plus, in fact, had levels exceeding 10. And there were several, 10 or more, that had levels that were basically 1,000 times the upper reference cut, over 100 nanograms per mil. So again, there was a big reaction going on here. Just a word about BNP, which so you can sort of regard as this comorbidity marker. Whether it's NT you measure or the total BNP, levels are elevated in the storm, maybe not to the same degree as the earlier ones I mentioned. There is a response to inflammation, but other factors like renal dysfunction kick in and can have an effect too. But the important thing about these comorbidity markers in COVID-19 is that they may be doing what they say on the tin, in that you've therefore with BNP got to consider is there heart failure present as well. And at this time I'll show you just one or two little cases that might help to illustrate that. Now, Dr. Leonard asked me originally to call this talk Data Everywhere. You can probably just about begin to get a feel for why she asked me to use that title. And the data was building up, and we developed these dashboards, which are rolling 10-day dashboards to display in an easy format the hyperinflammatory markers. And here's an example of one. We did this with our excellent laboratory ICT personnel. I'll name Tony Moulton, in cooperation with our excellent scientific team, who did a huge amount of work on getting these going. And we also kept a clinical and a laboratory database, and also an associated biobank was established, and we kept as many of these samples in the first wave as we could do, and we were enormously helped by Dr. Anna Rakovac, who obtained the ethics clearance for this, as well as the full lab and the clinical team who helped with collecting the samples, for example. Now, having that database enabled us, if you like, to go back and pull out data. So this is a work in progress, but I have some data here, which is preliminary analysis of the ICU, our ICU patients, and done in cooperation with the ICU department. And this shows 25 COVID-19 ICU patients. All of these patients, by the way, had a very long stay. You know, with COVID-19, it's not simply in and out of the ICU over 2 or 3 days. And we looked here at the marker trends on day 1, 7, and 14. In fact, we're able to extend it to day 28 as well, and further, hopefully. Now, this is the data everywhere a little bit, but it's a little bit easier just to see with these graphs. So one thing that was noticeable is that inflammation was mostly in the first 2 weeks. And you can see the top left graph, CRP and IL-6 there are coming down. They're not normal at 2 weeks, but they have improved an awful lot. The ferritin, which is the middle on the top there, the green one, improves also, but it does seem to lag behind, and it does seem to remain elevated at 2 or even 4 weeks in to these protracted ICU course patients. And PCT is showing in the bottom middle there. It also comes down, improves over 2 to 4 weeks. And one thing we noticed with PCT is that quite a lot of patients had blips during their course. Now, if there's time, I'll show you an example of that. The D-dimers and fibrinogen, they also tended to remain persistently elevated. They didn't really normalize in the ICU patients, even when they were being discharged from the ICU into step down. And on the far right, the PaO2 FiO2 ratio also improved. Now, it had a long way to go there. That's just a marker of hypoxemia improving. And you can see the lymphocytes picked up as well during the first 2 weeks, in fact, but a long way to go. Now, I think, Dr. hopefully there's a few minutes left for 1 or 2 patient journeys. And here's a 62-year-old gentleman. He was admitted middle of April, middle of first wave, with COVID-19 pneumonia into ICU the following day. Now, he did have an underlying condition in that he had a stent 15 years earlier for IHD. And he did run a very protracted course, this gentleman, 76 days actually. He was ventilated, which puts him on the WHO 6 score. Basically ventilation, invasive ventilation, but he managed to improve, and he eventually went on to oxygen via nasal cannula, which is a big improvement. It's down to a score of 4 in the WHO system. He was still desaturating on exertion, and he had other problems. He was stepped down eventually from ICU. Here's his dashboard, and I hope this was helpful to the ICU and the other clinicians. It's a rolling 10-day dashboard, updated every day, so a different 10-day window is visible. And you can see that there are massive elevations of many of his hyperinflammatory markers, and he also had low lymphocytes there as well. Now, this was a 10-day window, but we were able to use the database just to extract this chap's results, because he ran a protracted course. For the best part of 3 months, he was with us. And April, May, and June, in fact, this gentleman was in either ICU or elsewhere in the hospital. So I have his slightly full patient journey here. Now, the normal patient journey, by the way, is many stops, like ED to ICU maybe, to ward, home step down, and then to post-COVID clinic, for example. But as I mentioned, this gentleman came into ED, he was straight into ICU and had a protracted stay there for something like 76 days, I think it was, before being discharged. And then he wasn't sent home, he went to a ward. So we were able to extract his hyperinflammatory markers here, and here is his ferritin. And you can see that, as I mentioned, the first 2 weeks or so, he had this big inflammatory peak of the ferritin, which then came down. And that's about the usual range there for all the markers, actually. So you can see how high that is. And we also did his procalcitonin. Now, this was very interesting, actually, because his procalcitonin initially, now the scales are different, by the way, but it did parallel that high ferritin in the first fortnight. But then it more or less went to normal. And then he had this big spike, basically, in the middle of June. And in fact, it was found that he had a positive blood culture just around that time. The BC red is just a positive blood culture there. And of course, he would have had antibiotics, both the standard ones that were used and also tailored antibiotics as well during his stay. Now, his CRP is showing there in the red. Again, it sort of paralleled the ferritin. It was high initially, went down for 2 weeks, but with a lot of sawtoothing, was picking up all these changes. The ferritin doesn't seem to do that. It seems to average things out a bit, but it also stays abnormal for longer. His IL-6 is showing there. Again, it parallels the ferritin and the CRP. Lots of sawtoothing going on, extra peaks. But curiously, the IL-6 peaks look like they're a bit earlier than the CRP peaks. They're happening earlier, maybe a bit of earlier warning there. He also, of course, had other blood cultures. These green ones are negative ones, and he had various courses of antibiotics during his stay. And of course, he was intubated. He was getting invasive ventilation. That's a score of 6 on the WHO system. And when he was extubated, he was able to go to the wards, basically on nasal cannula oxygen, which is far from still being able to go home and breathe normal air. But he did make an improvement there. So I'll just move on in the last maybe minute or so to just one other patient journey. Now, this chap was only 17, 17-year-old man admitted to ICU. I mean, it sort of illustrates that this disease affects everyone, basically. And this chap was requiring invasive ventilation. Now, actually, the reason I want to show him is that he had this big spike in BNP. His BNP for a 17-year-old went to 26,000, which is a colossal value. And it was discussed with cardiology, of course. And I love the cardiologists, but they did what they did, which is they did an echo. And as I say, I love the cardiologists. And it was normal. So he didn't have heart failure. There's a query he might have had cardiomyopathy. And our excellent cardiology team considered that this may, in fact, this very big change might be due to a COVID storm type of effect. And so we drilled in from the database. That's his dashboard, by the way. Again, healthfully produced each day by the laboratory scientists and the ICT team. It's got the hyperinflammatory markers there, but look at the BNP, which is the third bottom on the left. And in that particular 10-day window, no BNP went less than 14,000. And in a 17-year-old, it should be more or less not detected, and 300 at the upper end, certainly colossal elevation there. But we did a full extract around that time, and the graphs are probably the easiest thing. There's a spike in BNP up to 26,000 there in that graph on the top right. You can see actually that it sort of parallels the CRP elevation. That might suggest that his COVID storm is doing it. But the other interesting thing was his creatinine did a spike. Now, if you quickly look at the numbers in the table, actually 17-year-old, they don't look so bad, but actually for a 17-year-old, they're fairly awful, actually. And on top of that, he had a spike up. He probably had an AKI injury, kidney injury event there, which might have pushed up that BNP again. So you can see that, that the databases can help, hopefully help sort out patients. So with that, I mean, I hope you found that a bit interesting, everyone out there, and that the cases were helpful. I'd just like to end by acknowledging the Tallaght University Hospital's excellent ICU clinical and laboratory medicine team who helped to pull all this together. Thank you very much.